Lalit Verma, and at the outset, thanks to AIOC and to the Novartis team for giving me this opportunity. So this is my disclaimer slide. So we all know that diabetic retinopathy is a vascular disease affecting the deep retinal capillaries. And when we look at the vascular changes which we see in diabetic retinopathy, it ranges from the earliest sign of microaneurysm formation to capillary leakage, and then formation of the non-perfusion areas, and eventually and finally leading to an irma and a neovascularization. So these vascular changes which you see on the clinical examination actually lead to structural changes in the retina, and that is what we try to figure out on the OCT. And these structural changes are mainly in the macular area. So when you look at an OCT in a patient with diabetic retinopathy and diabetic macular edema, this is the 10-step thing which I try to follow in every patient with DME. First, whether you want to know whether the disease or the macular edema is because of the diabetic retinopathy itself, identify the type of the macular edema, establish where the macular edema is present, also associate any disease manifestations, recognizing any disease manifestations to determine whether the severity of the leakage is high or low, then identify the effects of long-standing macular edema, look at the function of inflammation in DME, and identify whether there is macular ischemia and correlate them with serological markers, and then predict the visual prognosis. So when you look at the word biomarker, biomarker basically means it is useful for diagnosis, measuring the disease progression, and predicting and monitoring the effects of therapeutic interventions. And it is of great importance for individualizing the treatment. So there are a number of biomarkers which are important, which will help you in diagnosis, treating the patient, and then also following up these patients. The OCT biomarkers are very important. Why? Because they are non-invasive, they provide near histological assessment, and they are important in assessing the functional outcomes as well. So you definitely want to know whether your patient who's going to have an improved vision based on the OCT markers or not. So these are the guidelines, with a number of international societies also recommending the use of OCT to assess, monitor, and evaluate the response to therapy in diabetic macular edema. So the first thing which we try to look on the OCT is whether it's a tractional or a non-tractional edema, and whether it is center involving or non-center involving or center sparing. So this is a very important flowchart which actually tells us that in a tractional macular edema, diabetic macular edema, you have the various components of the traction, and here the surgical preference, surgical treatment is the preference of choice. Whereas in non-tractional diabetic macular edema, you try to look at the different types of macular edema where you would consider medical therapy as the treatment of choice. So these are the few OCT images on the left side which shows you that the tractional component which is present, whereas on the right side you have the cystoid macular edema and a combination of cystoid and neurosensory detachment. The non-tractional edema is dependent on, now you need to look at the next step, whether it is center involving or center sparing. If it is center involving, the treatment would be with intravitreal injections, whereas if it is sparing the center, there could be a combination of laser photocoagulation which can be added to these cases. So these are images which show that the top one is the non-center involving diabetic macular edema, whereas the bottom one, it shows the presence of a cystoid macular edema. There are some fluid markers or OCT markers which determine whether there is increased leakage or increased activity, and one of the most important one is the measurement of the central macular thickness, the fluid activity, and the hard exudates. So when you look at the central macular thickness and the retinal fluid, you know that basically the fluid accumulation in diabetic macular edema happens because of the breakdown of the inner blood retinal barrier, and the presence of an increased central macular thickness means there is reduced visual signal transmission, and therefore, but it is not always that when you have a high retinal thickness, the visual acuity is low in these cases. But there are a number of clinical trials and studies which take the central subfield thickness as one of the important OCT markers for measuring their outcomes of the study. Even the improvement in the visual acuity is documented by a reduction in the central retinal thickness with anti-VEGF therapy in most of the clinical studies. Even in this RESOLVE study which you see, you can see with the reduction in the macular thickness, there is an improvement in the ETDRS letters in these cases. The second important point is the presence of fluid in different compartments, the intraretinal and the subretinal fluid, and there is a difference between the fluid in a diabetic macular edema case versus a AMD case. In a diabetic macular edema, it's primarily because of the breakdown of the inner blood retinal barrier, whereas in an AMD case or a neovascular AMD case, it's because of the damage to the outer blood retinal barrier. The intraretinal and the subretinal fluid, they are all associated with disease activity, but the intraretinal intraretinal fluid is more prevalent due to the breakdown of the inner blood retinal barrier. So you can see that even in all these post hoc analysis with the protocol T, the Vivid Vista and the Apollon studies, they clearly showed that the IRF is more commonly present than the SRF, but both the fluids component, they indicate activity. Both the presence of fluid in both the compartments, the intraretinal fluid and the subretinal fluid, they are associated with reduced retinal sensitivity and reduced function. And you can see that as the size of the intraretinal fluid or the large cyst keeps increasing and that there is a development of the subretinal fluid, the retinal sensitivity keeps dropping further and further down. So both intraretinal fluid and subretinal fluid are associated with a poor best corrected visual acuity. So in DME, all the fluid is considered to be pathological, and it's not like an AMD case where you can leave a cushion of SRF in a DME case. You cannot do that. Now let's look at the other factors which are suggestive of activity. This is the presence of hard exudation. These are lipid-laden macrophages or lipoproteinaceous material which is associated with fibrin and fibrinogen. And you have this another important paper which we published recently, which is suggestive of the intracystic hyperreflective material, which is a combination of heme, exudates and fibrin which is present there. So this is one of the photographs of the OCTs which is showing how the patient started with. Then there's development of a cystoid space with a hyperreflective material. You start treating the fluid cavity. The fluid cavity reduces, but the hyperreflective material resolves over a period of time. So this is the publication which I was talking about, where we talked about the intracystic hyperreflective material in Cessner involving diabetic macular edema. There are some important OCT biomarkers which talk about chronicity, and one of them is the bridging retinal processes which you see on the OCT, which indicates that there is a stretch on the bipolar cells, and therefore there is a reduced retinal sensitivity. And another important finding is the presence of a pearl necklace sign, where you can see all the hard exudates getting accumulated along the wall of the cyst. Very important marker which we talk about is the presence of hyperreflective foci, and these hyperreflective foci are basically because of the breakdown in the inner blood retinal barrier. And there are multiple theories which have been postulated for this. This can be extravasated lipoproteins, activated microglial cells, or even migrated RPE cells. Their size is less than 30 microns. They do not cause shadowing, and they are present from the inner to the outer retinal layers. They signify inflammatory markers. They respond more better to corticosteroids, and the presence of the hyperreflective foci in higher numbers suggests that there is a more likelihood of recurrences of diabetic macular edema to develop. So when you look at this comparison between the hyperreflective foci and the hard exudates, there is a number of differences ranging right from the size, the location, shadowing, and the reflectivity which you see between these two entities. Now, there is another recent publication from our end which we spoke about the cholesterolization of the RPE, where we called it as the onion ring sign. You can see this linear hyperreflective crystalline deposits which are present both in the inner retinal layers and in the RPE level, and this is one of the markers which suggests that there is a conversion of the hard exudates to cholesterol, and if they are present at the RPE level, they will lead to permanent destruction in the visual acuity. So there are a few OCT markers which talk about poor vision. One is the presence of the drill, where there is parallelism which is lost in the inner retinal layers, and they signify that there is a poor vision which is present, especially if the drill is present within the 1 millimeter central retinal zone. And this is all because of the neural retinal disorganization which happens in patients with resolved, which is a marker of visual acuity, especially in cases of recurrent macular edema. So you can see that the drill, this is the presence where there is a edema, macular edema and the drill, but the drill is basically has to be diagnosed when the macular edema is resolved, where you see that there is no parallelism which is present between these layers. Now, the drill is not specific for DR, and when you look at the drill in correlation with the OCT angiography, the presence of the drill indicates that these are the areas where the capillary dropouts are present, and that is why there is a disorganization on the retinal layers on structural OCT. The other important prognosticating find is the presence of the ELM ellipsoid zone discontinuity. So you can very clearly see with the white arrow that there is a destruction or a discontinuity which is present in the outer retinal layers, which is suggestive of a poor prognosis. So when you look at the factors which indicate poor prognosis, these include drill, which leads to mild to moderate vision loss, which signifies macular ischemia, the outer retinal layer disintegrity, which indicates that there is a damage to the photoreceptor layers, and the RP, which indicates there is a probable severe vision loss, and the recently published one where we called as the hyperreflective crystalline deposits, which if present at the fovea will lead to severe vision loss. So this is a worksheet which we are working upon, trying to answer these 10 points on the OCT, and then trying to establish what would be the visual prognosis in these patients, what would be the treatment options which we should consider, which intravitreal agent should be given, what regimen we should be following, whether it should be monthly dosing, PRN dosing, treat and extend, and what could be the probable or predicted visual outcome which is seen in these cases. So this is what I wanted to say. It's not always visual acuity. The visual acuity may be a starting force for guiding your treatment, but eventually it is the OCT biomarkers which will determine whether you need to continue treatment, stop the treatment, and predict the visual acuity or visual prognosis in these patients. Thank you very much.
Thank you, Ramesh, for highlighting the importance of OCT biomarkers. So one direct question is, do you treat based on visual acuity or OCT biomarker? Do you treat based on OCT biomarkers or visual acuity or both?
So my initial treatment is basically
May I request,
so the initial treatment is based on the OCT. From the OCT itself, we will come to know what is the traction, non-traction. Then you decide
no,
whether.
those things are very clear. You see, fractional, center involving, non-center involving, I think. But issue is which OCT biomarker, or may I ask you if patient has drill,
So
and if patient has disruption of ellipsoid zone.
So
apart from giving a poor prognosis, do you treat them still?
No, not really. The hyperreflective foci is one additional thing which probably I will try to look into, which will suggest that there is inflammation or no inflammation.
And any of the OCT biomarker tells you that this patient should be treated with what agent?
Yeah. So the
I'm talking of center involving DME non-tractional. Any OCT biomarker tells you that what agent should be used. I'm sorry, this echo I can't help, but there is because of the increased size of the hall. But my question is, any of the OCT biomarker in a non-tractional center involving macular edema, does it guide you that you should select this agent versus this agent?
So if there is a presence of a cystoid edema with a neurosensory detachment, probably we all tend to go towards steroids because we all feel that there is increased activity which is present and inflammation which is causing the neurosensory detachment, or even a potent, very potent anti-VEGF agent, which would probably be an aflibercept or a brolucizumab in those cases.
Okay, anybody has any point or question which is what Dr. Ramesh has said, which is different than the others? No, I agree, OCT biomarkers have played more and more role, but even if it is a traction macular edema, sometimes we may, give injection. It's not that once you find OCT, this is a traction and you straight away jump for surgery.
No, if it is not center involved, means if the traction is away from the center and not involving the center, and if the tractions are not very vascular, then in those cases anti-VEGF we can avoid and then still go ahead and treat them with steroids.
Okay, thank you, Ramesh. Time is not on our side because we have to cover 3-4 more talks, and now we have none else than giant from the east, Anuradha Maiti, to tell us about breaking the clinical dilemmas. You see, what Maiti is going to tell us is whether we should treat DME aggressively or maybe, PRN kind of regimen can be done, SOS kind of management can be done. Because in AMD, we all understand that, we have to give monthly injections. What about DME, Maiti? You want initial aggressive treatment or you want PRN?